Well, Professor Human Jalai is very competent indeed. He's an excellent speaker. He's well in control of the literature, of the technique, with lots of experience. So it's going to be really hard to convince you of the reverse, but I'll have a go. So this debate is about endophlebectomy, whether to use endophlebectomy in extensive occlusive venous disease or not. And I'm obviously against. And here is why. Well, if we go back, the first description of endophlebectomy was by the fathers of deep venous disease, Robert Kistner and Bob Eklow, and this was in 2004. And they described surgical disobliteration of the deep venous system. They used this on the common femoral vein and the femoral vein. Really, the procedure was never very popular until 2010, when the group of Camerata and his colleague published one case where they used a combination of surgery and iliac vein stenting. And this was the case. That's a pre-operative image showing post-thrombotic change of the iliac vein. And that's the common femoral vein being opened up and the synec removed and then patched, and then the stent was applied. And this technique was very rapidly became popular, and the same group 2 years later published a series of 10 patients where they reported on the good effect of this procedure on the quality of life of their patients. In 2017, Human Jalai and De Wolf and their colleagues published an addition to this procedure, and that is the arteriovenous fistula. So they added an arteriovenous fistula using PTFE from the common femoral artery to the common femoral vein, aiming at improving the patency of iliac vein stenting. And this procedure actually became the standard. Now, endophlebectomy. What's the justification of endophlebectomy? The justification, as we heard from the past 2 or 3 presentation, is to improve the flow into the stented iliac vein, because if there is poor inflow, the stent will occlude. By disobliteration of the common femoral vein, we also disobliterate the orifices of the femoral vein and the profunda femoris vein, as you can see in these images, and therefore the flow into the iliac stent improves, and in theory, patency improves. I'm sorry, I keep going back. But endophlebectomy is not a minor procedure. Endophlebectomy is a major procedure. And this is a publication by Human Jalai entitled Wound Complications After Common Femoral Vein Endophlebectomy and Its Influence on Patency. Now, let's take a look at the potential complications of endophlebectomy as published by Human Jalai. Well, it's not a quick procedure. It takes, in average, 5.5 hours, plus or minus 2 hours. So you need to spend the whole day there. And quite a bit of bleeding. Minor bleeding in about 10% of the patients. Major bleeding requiring transfusion in about 6%. And this is very expected because it's a major procedure performed on a patient with lots of venous channels, and the patient needs to be on full anticoagulation during and after the procedure, so they're expected to bleed. Not only this, but full 1/3 of the patient had significant wound complications, and among those, 26% had lymphatic fistula, quite problematic. We are all surgeons and we know how lymphatic fistula in the groin is a problematic problem. Not only this, but those who had wound complications, this had a negative effect on patency, and that's from the same publication. The lower curve is for patients who had wound complications. So wound complications would negatively affect iliac stent patency. Now, what's the alternative to endophlebectomy? It's very simple, and that is to stent the common femoral vein. So let's take a good look at these images. That's a typical image of a patient who has complete occlusion of the common iliac vein and external iliac vein and the common femoral vein. Now, where the inflow is coming from? It's coming from the profunda and the great saphenous vein, which is very commonly ignored, and then it stops here. Now if you stent the common iliac vein and external iliac vein and you skip the common femoral vein, obviously there will be very poor inflow into the stent. So what do we need to do is just to extend the stent into the common femoral vein in order to have flow from the profunda as well as from the great saphenous vein. And I'll share with you some examples. This is the first case. Actually, this is what not to do. So this patient has total occlusion of the common iliac and external iliac vein and the great saphenous vein. And what you see here, that's the great saphenous vein. I said occlusion of the common iliac, external iliac, and common femoral vein, and that's the great saphenous vein. Now, the lesion was crossed, and then it was dilated, and what I would like you to appreciate is the severity of the common femoral stenosis. We cannot ignore the common femoral stenosis. And here the common femoral vein stenosis after dilatation. This is the flow after angioplasty. There is nothing much happened, and these two veins are actually the great saphenous vein and the profunda femoris vein, and there is no common femoral vein. So a stent was deployed, and this is the distal end of the stent. And as you can see, the part of the common femoral vein was skipped. In fact, this stent thrombosed within 48 hours, and this patient had to have thrombolysis and extension of the stent into this area, and then it remained patent now for 5 years. This is the mistake. This is what one should not do. And I'd like to share with you this second example. That's another patient who had the same total occlusion of the external iliac, common iliac vein, as well as the common femoral vein, and the lesion was crossed and then was dilated. So the lesion was dilated, and I'm sorry. And the stent was deployed, and you can see the end of the stent here, which is not including the common femoral vein. Now, if we leave this patient like this, it will occlude, obviously. So this part of the common femoral vein was dilated, and the stent was deployed, and here is the end result. That's the great saphenous vein and the profunda femoris vein draining into the stent, and this stent remained patent. A third and last example. Another way of approaching this problem is coming from above alone. So again, that's the great saphenous vein, and this lesion was approached from a crossover technique. You can see the catheter here, and then that's a combination of antegrade and retrograde axis. And what you see here is the stent before being deployed. That's a great saphenous, and that's the profunda femoris vein. The stent was opened up, and then it was pulled back until it stopped exactly here. And this is the end result, with the great saphenous vein and the profunda femoris vein draining into the stent. So, in conclusion, Mr. Chairman, in extensive occlusive venous disease, endotheliectomy is not the best option because associated with so much significant problems. An alternative would be the common femoral vein stenting, but I would totally agree with my colleague Human July that in stage 5, where there is no inflow, this procedure should not be performed. Thank you.